No.
Close the doors.
Does anyone have wet wipes?
Hello?
Does anyone have wet wipes?
Yes.
Okay.
Abailan?
Dr. Amin,
Yes, sir.
yesterday you were talking lots about Mali.
Miley, yeah.
Yeah. And now you are saying that they have to use Ellanse. Why?
Okay, right. I don't think it's fair to compare hyaluronic acid with Ellanse.
Why?
I will tell you now through this presentation.
Okay.
Okay? Right. All have coffee? Yeah? Awake? Right. Ellanse. Who has used Ellanse before? Show me hands. Okay, 2 out of everyone? 3? Who had Ellanse in their face? 4? Okay. So Ellanse is a filler and a biostimulator. It's not a permanent filler. It's not a semi-permanent filler. It's a filler that stimulates collagen. So, when this whole injectable business started happening, yeah? When it first started happening, plastic surgeons jumped in and said, this is ours. We should be injecting it and doing botulinum toxin, right? And then dermatologists said, whoa, it's in the skin, it's our job. Yeah? GP came up and said, if they could do it, why not us do it? Dentists came in and said, hold on, this is in the head and neck, it's our specialty. So they started making names out of it. Either calling it, can I ask kindly to close that door because there's some noise coming from out there. Just that far door if you can close it. Thank you. Perfect. So the first, they started calling aesthetic medicine, minimally invasive medicine, minimally invasive procedures. What I love about it, the best name I would like to call it, is anti-aging medicine. Because that's what we're trying to do. And in order to treat it the right way, we need to understand aging and what happens in aging, what we lose, what are we trying to replace. We will never make a 40-year-old look like a 30, a 50 look like a 40, a 60 look like a 20. That's not our job. Our job is to make a 40 to look like a healthy 40, a 50 to look like a healthy 50, and 60 to look like a healthy 60. And that happens through combination treatments. It's not through one treatment only. That happens through injecting materials that not only fill, I always say, I remember the first course I ever took when it came to fillers, a nasolabial, you inject the nasolabial, boom, that's it. Later on we realized that's not the case. We need to understand what causes the nasolabial, what are we losing, which soft tissue are we trying to replace. We realize that it's not only volume that we're working on, we need to work on skin texture, we need to work on skin hydration, because the collagen stimulation is not the same. And that's where Ellanse came in handy, because Ellanse has both. When we look at aging, we have different phases of aging. The most important thing that we have, I'm not talking about aging in our 60s and 70s, I'm talking about 30s to 50s. We start losing, the bone support we still have it, we're not losing much of it. But what we lose is fat. We lose superficial fat and we lose deep fat. The superficial fat is the fat that we gain and lose with gaining and losing weight. The deep fat is the fat that we lose when we, starting from the age of 30, on yearly basis each year. Now here's what's interesting. The superficial fat and the deep fat are not equally distributed in the face. In certain areas in the face, you have more deep fat than superficial fat. In other areas in the face, you have more superficial fat than deep fat. Why is that important to us? Let's think of areas in the face. Think of someone who lost 10 kilograms of weight or 20 kilograms of weight. I'm sure you know someone. After a gastric ban, lost 20 kilograms of weight very rapidly. Where's the first thing, where do you see it in the face? The first part of the face you see it. Cheeks. So what is that telling me? That's telling me we have more superficial fat in the cheek than deep fat. So if I'm treating a patient for losing weight, I need to replace that. And I need to choose a material that hits that area. I need to choose a material that I trust, that when I place that area, it's going to replace the soft tissue. Right? It's not only going to fill. I need something that's going to stimulate collagen. Does that make sense? Now let's go put our thinking cap on again. So a patient comes in, think of a relative you have who is 90 years old, very slim, very skinny. Where do you see the most hollowness in the face? Temple. So what's that telling me? In the temple area, there's more deep fat than superficial fat. Therefore, in the temple area, if I am to choose to restore volume because of aging, I'm going to go very deep. And maybe I will choose fillers for that, hyaluronic acid, because I want to fill that area. I want to get it bigger, I want more support. Does that make sense? I'm not here to tell you where to use what or when, but this is what it needs to be. With the respect of the anatomical landmarks, the facial artery, for example, is something very important. When we talk about anatomy, it's all about the depth of the anatomy. Who was here on, when did we arrive? Which day? Sunday, Friday, when we did the anatomy thing, the drawing. It's all about the depth of the anatomy, how superficial, how deep, where it is exactly. Is it in the middle, is it too superficial, or is it too deep? And accordingly, I decide where I'm going to inject it. I know that the facial artery pops up from the external carotid, goes anterior to the mesenteric, and goes like a zigzag. So I know in this area I need to inject deep. Then it branches into the superior labial artery, into the angular artery, it goes up to the lateral labial artery. I know for a fact that the inferior labial artery is behind the muscle. So therefore, if I want to inject filler, I need to inject anterior to the muscle. Those are all anatomical landmarks we all know. But the interesting thing is that the anatomy is not. We always know that the labial artery, for example, that for example, that is behind the muscle. But then more research happened, and we realized that that's not always the case. It's behind the muscle in 75% of the cases, and the rest of the muscle anterior to it. So don't take the anatomy for granted. The trick is to inject very, very slowly. Over here, we have something very important, which is the lateral and dorsal nasal artery. There is no such thing as safe zone in the face. That does not exist. Okay? There are safer zones than others. But when we're talking about depth, if we talk about the dorsal lateral nasal artery, or the angular artery, we know it's running along the lateral side of the nose. Do we know how deep superficial it is? Tell me, do you think it's deep or do you think it's superficial? Sorry? Both? Who said it doesn't matter? Exactly. We don't care. Because this area is very thin. You won't be able to avoid injecting superficial or deep in that area. Therefore, you never inject the lateral side of the nose. Think of that as well. So it's all about safety. And the other thing, look at those arteries and vessels. Look where they go. Look what happens. Go back, 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 back. What's happening here? What's this artery here for? The ophthalmic artery. The ophthalmic artery. And this is how blindness happens, Lord God forbid, when you inject. A bolus comes in and it travels along those arteries up, goes back, and blocks this artery here. So you block the blood supply that gives the eye the vision. And that's how blindness happens. And they say from reversible to irreversible, I think the recent research says you've got 15 minutes. So just be very careful, be very aware. Be very aware of this danger triangle. Because the danger triangle, the arteries in the danger triangle, they all anastomose with the ophthalmic artery. And they are valvular, so any infection could go back straight to the brain and cause cavernous sinus thrombosis. Why is that important? If you do have an issue in the danger triangle, treat it aggressively. Treat it with IV antibiotics, treat it with steroids as well. Don't just send an antibiotic prescription on WhatsApp and ask the patient to come back. The risks are very low for it to go serious, but if it does go serious, it is going to be very worrying. Ellanse has been on the market for quite a while. In 2006 it started.
These vascular accidents are reported with Ellanse also?
Okay. Vascular accidents throughout 10 years, when we were celebrating the 10 years anniversary of Ellanse, we had one report. So over 1 million syringes were placed, and we had one reported intravascular injection only. So I think we're doing good.
So it says it's much safer than HA products.
It is safer than HA products, and I'll show you why now when we have the cameras, and I will cause a heart attack with the company that are giving me the Ellanse, because I'll be wasting some material. So
there is one more thing that you have to remember, that whenever we talk about complications, remember there is a group of irreversible complications. If you are not going to treat them immediately or within due time, and that damage, if it has been done, either it is in form of skin necrosis or retinal damage or ophthalmic artery damage or sometimes cerebrovascular accident, then they are permanent damages. So whenever you think that this complication is going to occur, talk to your patient, try to treat them immediately, or call them back after 6 hours or next day. Thank you.
okay. Now, so Ellanse has been on the market for quite a while. The fact that this is the thing, this is what I love, right? When we all study evidence-based medicine, when any medical rep comes in, the first question you're going to say is, why is this safe? How long has it been? What studies have been done? And there have been a lot of studies on Ellanse. Some studies showed complications, and other studies showed safety. The studies that showed complications, we have to go back and think what caused those complications. And therefore, always, in Sinclair, we are trying always to improve. I travel around the world not only to share with you and gain experience from you. Your feedback is very important, because I take that feedback and I sit behind closed doors to report and see how we could improve any product to make it more safer for the patient and more satisfying for the doctor. And I've heard a lot about Ellanse. And slowly, we didn't change it the way we do it, because it's been exactly the same, but slowly we made sure to highlight the technique, because what we realized, the most complications we get is because of techniques, as simple as that. And maybe years ago, we weren't very clear and very, very loud about how it should be injected. But today we are very loud about it. So, yeah, we celebrated more than 1 million syringes being sold. This is how Ellanse happened. It's an injectable implant. It lasts long. Please don't call it permanent fillers. Please don't call it semi-permanent fillers, because it's not permanent and it's not semi-permanent. It completely dissolves. It takes longer for it to dissolve, but it dissolves completely. And it does have a high safety profile. It comes in a box as a syringe, 1 mil syringes with 27 gauge needles. It comes in different sizes, S, M, L, E, E is going to be scrapped very soon. We have S, M, and L, depending on how long it stays. Now, this is how Ellanse works. Ellanse is composed of two factors, carboxymethylcellulose and polycaprolactone. Where do you remember, where have you heard of carboxymethylcellulose before? It's in wound dressings. More importantly, it's in burn dressings. Why would I want carboxymethylcellulose in burn dressings? Why was it used in burn dressings? Because it stimulates collagen and it makes tissue. God forbid if anyone has ended up with a burn, end up with loss of tissue. So when you place carboxymethylcellulose in it, you need that tissue to regenerate, and so you need it to form normal tissue. And that's where carboxymethylcellulose comes in handy. Polycaprolactone are small particles that are present in the gel of carboxymethylcellulose. So after injecting Ellanse, what happens is, so when you inject Ellanse, you end up with immediate filling because the material itself fills the area. And then you have long-lasting volumization through collagen stimulation. This is a very important chart for you guys, for Ellanse injectors to be aware of. The carboxymethyl, when you inject it, the cocktail goes into the tissue. Slowly, the carboxymethylcellulose starts working. As it starts working, the dissolving of it starts stimulating collagen fibers. The collagen fibers start holding the particles together. Okay? Now, this process, sometimes what happens is, this process happens in week number 5 to week number 8. So it happens about between 1 month and 2 months. So a patient after injecting Ellanse might come after month number 1 saying it has gone down. But it has gone down because the carboxymethylcellulose effect has dissolved and the collagen formation still hasn't formed. The reason I'm telling you this, don't jump in to inject and fill again. Send your patient back home, ask her to come back in 2 weeks, and then inject and assess. Because I've heard this sometimes happening, where patients do that. Don't jump into injecting more. Always underachieve. Ellanse is injected in the subdermal and supraperiosteal layer. Personally, I go up to the dermis as well, very recently, because I stick to the rule. It could be injected anywhere, except 3 places. Never inject the glabella, don't inject the nose, don't inject the tear trough, and don't inject the lips. Why? Ellanse's changes in size you can't predict them 100%. If you place 1 ml of Ellanse, it doesn't mean you're going to end up with 1 ml of volume. You might end up with 1 ml of volume, but you're more likely to end up sometimes with 1.2 ml of volume because you're formulating collagen. Now, if you inject that area under the eye, if a patient needs 3 ml of volume, 0.3 ml of volume, she needs 0.3 ml of volume. She doesn't need 0.4. 0.4 will look straight away, you'll see the difference. In the nose, the same thing. Every little mil makes a difference. But in the cheek, in the jawline, the more the better. I don't mind having a little bit more. So therefore, make sure you inject it in the right areas. And this is how, so you end up with a natural look, you end up with good normal results that last for quite a long while. Those are the polycaprolactone particles. Now the difference between the S, M, L, and E is the polycaprolactone chains. If you look at, this is how you need to think of it. If you have a spaghetti, right? The syringe itself, when you inject it, unlike fillers, it's not like the different lines have different viscosity or different flowiness. It's exactly the same when it comes to Ellanse. It's the chain of the polycaprolactone sphere. So it's those sphericals inside either has long spaghettis or short spaghettis. If it's a short one, then it's an S, you can chop it and easily get rid of it. The longer it is, the longer it takes to dissolve. So the technique is very important. Mark the areas that you want to fill. Inject small volumes. Okay? The secret number in Ellanse, the key word, the golden number, is 0.2. Never inject more than 0.2 in one area. Inject more than 0.2 in one area, you're going to end up with complications if you're going to do it bolus technique. If you're doing it threading or tunneling, each 1 centimeter of that tunnel should have 0.1. As simple as that. Stick to those two golden rules, you will not end up with complications, I promise you. Because the most complication I hear is nodules. Nodules happen when you over-inject the area. Drive a Ferrari, crash it in the wall. It's not because the Ferrari is a bad car. It's because you drove it the wrong way. So don't blame, stick to the rules and it'll be fine. Any filler can have adverse effect when you inject it the wrong way. I do expect inflammation, redness, swelling after injecting Ellanse more than hyaluronic acid. And it's normal because that's how carboxymethylcellulose work. You want that inflammatory reaction. This is part of what's going on. Don't worry, don't let it scare you. But more importantly, stick to the golden rule, the 0.2 mil. This is what you need to do. When you do Ellanse, the patient once you first start with Ellanse, once the Ellanse completely wears off, we don't go to ground zero. We end up with improvement because collagen stimulation has happened. So this is another patient. This is 1 month later. After using S, this is 20 months later. There's no more Ellanse in her face, but her skin texture has improved, and her face and the volume has improved as well. So that's Ellanse for you. We've got a patient to see how we inject it. Any questions at all? We all okay?
How much volume per head if you are injecting in head? How much do you give?
How much do I give volume in the hand? Depending on the hand, I'll show you now how I do the hands. If it needs a lot, then I can be comfortable placing 1 mil. If it doesn't need that much volume, I would put 0.5 mil. It depends on the hand, it depends on what you see. Treat it like fillers. So see the results straight away. But I have a special way of doing the hands, and I'll show you now how to do the hands. But speaking of the hands, take a history of what the patient does for living. Because the hands are going to swell and they're going to go red. And this is like a textbook thing that always happens. Every time I do hands with Ellanse, for a patient who is an Ellanse virgin, I tell the patient it's going to swell. 24 hours down the line, I get a photo on WhatsApp with her heart swollen with red saying, what have you done to me? Every single time. 1 week down the line, she says, I love it. And they keep on coming back again and again and again. I saw a few good friends here in Pakistan that I've done hands for last visit 2 years ago. And they've asked me to repeat it again because they loved it. So it's just a beautiful result. Okay? Right. Let's do the demo. Aesthetic gynecology.
Okay.
So M and L is more used, in my personal experience, for aesthetic gynecology. In the face, I personally use S in most of my cases. I have patients who've had M in their faces and they want it again. But in most of the cases, I want my patients to come back in a year and a half.
Okay.
Yeah.
So it's better to remain on
Got it?
Gal khatam ho gayi hai.
Importantly, again, I don't know I hope this wasn't present in Pakistan, but in the Middle East at one point, there was a lot of permanent fillers going on.
There's a time that we also use lot of permanent fillers.
And unfortunately, in certain areas in the Middle East, they are still doing it. Now, patients who have had permanent fillers in my clinic, the only reason they would sit on my chair is for the permanent fillers to be removed. Other than that, it is a ticking bomb. I would strongly advise against doing anything.
And one thing that if she is the patient who is coming first time to you,
Yeah.
will you prefer to do it with the HA filler or straight away you can use Ellanse?
Let me put it this way. If I have the choice, I would always choose Ellanse. Because Ellanse gives me two actions, filling and collagen stimulation. But not everyone can afford Ellanse.
Okay.
So therefore, and you have to be very careful with your patient selection when it comes to Ellanse. Because with Ellanse, one, the first 24 to 48 hours might not be very pleasant for the patient because of the redness and the swelling.
So this is a common sequel of the treatment.
Yes.
It's going to happen.
I always tell my patients.
Yeah.
But once that part goes, and the filling effect happens, the patient gets satisfied. 3 months down the line, she'll be walking into a dinner and people looking at her face saying, "You're still glowing, what have you done?" When she wouldn't have done anything. Right, Marianne?
Yes, very true, very true. He stole my story, my personal experience.
It doesn't interact with us, no.
The radius?
No.
No?
It's different. It's a different.
No, yes, I know
A
it's
wise
different.
doctor once.
But
Huh?
A wise doctor once told me.
It's different. Radius is a beautiful product. I'm not here to say one is better than the other. If I want hard tissue, I would go for calcium hydroxyapatite. If I want soft tissue, I would go for polycaprolactone. As simple as that, but please kill it here.
okay. Because both of them are looking like
The difference between hyaluronic acid and Ellanse, okay, and why it's safer in a way, and why we haven't got one, we don't place more than 0.2. Two, here's hyaluronic acid, and I'm going to place 0.2 of that here.
oh my god, you are wasting.
I know
Why
that.
2 ml? You had injected it somewhere else?
All I want you to do other than here, look at their faces. Right? And then I'm going to place 0.2. 2 minutes, please. Closer. Perfect. Now I'm going to place 0.2 of Ellanse. Right? Now, regardless of how much I'm going to rub the hyaluronic acid, and I've used precise with the smallest, which is the most flowing. Can you see? Precise mind. Regardless of how much I'm going to rub, can you see the particles? Yeah? So hyaluronic acid is hyaluronic acid. Particles will always be there. Can I have a swab, please? Swab, gauze, please. Gauze, sorry, gauze. Now, however, look, I still have particles. However, when it comes to Ellanse, look what happens now for the same amount when I start rubbing it. Very creamy. So it's
easily dispersible and it will go away.
it goes away. So therefore, this is why it's less likely to cause problems. It's less likely to cause damage. Does that make sense?
What is your opinion if we use it in the tear trough or in the periorbital area?
It should not be used.
It should not be.
We said that contraindicated at the tear trough, nose, labella, and right.
But you know, it gives you attraction. Why? Because you know that whenever we inject acid filler in the periorbital area, it usually gives tindal effects. Why this is not a transparent gel?
Yes.
I think that it will not give. So why it is contraindicated?
Because in that area, it's a thin area. And I can't, one, it's in the perioral area. If it's there, I can't get rid of it. And I can't predict exactly how much volumization is going to happen in about 3 months' time because of the collagen stimulation. And under the eye, every mil makes a difference. Every little lift makes a difference. So let's start off by marking what I'm going to do. So for her, when I want to assess the cheeks, for example, I could see flatness in the cheeks, right? But if we are to see the flatness in the cheek, I would like to give her a little bit of anterior projection. So I start off by drawing the area that I think needs flat filling when the patient is static. And then I'm going to ask the patient to smile. Smile for me. And then I'm going to mark the, smile more. Perfect, more. So it's a smaller area. If I fill the area that I thought it needs filling to start off with, she smiles, she's going to end up with her eyes getting closer. So that's why I do it very gently. Let's have a look at the nasolabial. The nasolabial could do with a bit of Ellanse as well, and the marionette could do with a bit of Ellanse as well. So I'm going to, just for you to see, 2 techniques. I'm going to do a bolus technique in the cheek area, although I usually do fanning, but it's worth for you to see. And then I'm going to do the cannula fanning in the nasolabial and the marionette part. So I'm going to do the right side, and then see the difference between the right and the left, okay? So, relax.
मैं किसी की सलूटी की चाबी भूल गई तो इधर काउंटर में पड़ी है. There is one more question.
Yes.
Again, you will say, don't say in front of them. What do you think about her jawline? Can you improve her jawline with Ellanse?
Of course I can. Ellanse could improve jawline. It will give me soft tissue, but it will give me a nice jawline. But I would prefer lifting from the top because I want the collagen stimulation with Ellanse, and then decide whether she needs anything in the bottom or not. You want me to say, I know where you're going to, and you won't take it from me. I will not be saying it today.
Okay.
Right.
No radius.
So I'm going to start off with the needle. Out of the way. And I know I'm going to place here, I would like to place 2 points. Oh, actually, sorry, let me rephrase. I want to put 0.4 in the cheek, but I'm not going to put it in 1 point because, as I said, the golden rule is 0.2 and 0.2. So what we're going to do is, here's the first 0.2 going in. I've hit bone. Very gently, I'm going to give, here's one. Okay? Okay? See, I haven't moved my hand at all. I'm using a needle, so I'm going to pull out very slowly. There's another 0.2. And I chose another place. Give that bolus.
0.2.
0.2.
Have you ever experienced any vascular accident in the infraorbital artery?
With Ellanse or in general?
In general.
Yes, I have.
Okay.
And it showed 24 hours after, actually, when injecting, and that's why I'm now, as a rule of thumb, I always use a cannula. And
There is a question.
2 points are fixed.
Two.
Can you leave volume somewhere else on the face?
You can do anywhere you want. But when I assess the patient, I notice that this is the area that needs volumization. But yeah, you can go back to the sarcoma, you can do whatever you want.
You are not pulling back your cleanser. Why?
Because if I aspirate, I won't, even if I aspirate, even if I'm vessel, the way it works, I won't get blood. It's not like hyaluronic acid. The pressure won't help.
But you told us yesterday.
When you're using hyaluronic acid,
Yeah.
not Ellanse.
I have counted 7. 1, 2, 3.
But that doesn't work at Ellanse. You won't. If you're, let's put it this way. Get a series of Ellanse. I'm not going to waste any more Ellanse. Put it in the cannula, please. Put it in the cannula. But get a series of Ellanse, pop it into a glass of water, and aspirate. It will never come out. It doesn't work like the same pressure. So therefore you won't. Okay? Now I'm going to fan here and here. And the best way to assess, I wish we could have a camera, because when you want to assess cheek contouring, you should always go from behind the patient to see the contour. And if you come from behind the patient here, you'll see how the cheek is now contoured more. Thank you. Head up, head up, head up. Here's one. And over here now, I place 0.2 here. I'm going to place 0.2 in the nasolabial and 0.2 in the marionette, but I'm going to fan it. So it can't be in one place only. So I'm just going to keep my hand moving. And remember what I told you about the rule of fanning? When you want to do fanning, or when you want to do a tunnel, each 1 centimeter should have only 0.1. And here's another one. Can we have the hands model ready?
Yes.
I am a fan of not putting any bonus with this stimulatory filler at one place.
That's fine. That's even safer and safer.
No, because if they are stimulating, there should be a thin film everywhere, because these molecules, they are going to stimulate the skin.
Yeah. Okay. Can I have some topical, please? So we're going to sit her up, so can we please have that camera ready? And remember, I've placed in the right side of the face 0.4, 0.2 and 0.2, so a total of 0.8 minutes. Okay? Let's see if that made any difference. Okay, sit up for me.
Given.
One.
That's great.
Yeah.
Good job.
Yeah?
Yeah.
Bit of contouring here.
Yeah.
The marionette and nasolabial compared to. Okay? So I'm going to do the other side now. Needle first.
It's on the bone.
Yes. Yes? Cannula.
You have injected 0.8.
0.8 on the right side. 0.2, 0.4, 0.4.
It means that you will be left with 0.4. So you have to use these 0.4 in this patient.
0.4, sorry, 0.4, 0.2 and 0.2. So
So I have 0.8 and 0.2 I wasted in your hand.
Oh, then put something more. Yes, if there is any vascular complication with Ellanse, what you will do?
I would wash it away with saline. I would still give hyaluronidase, and I would try. But the secret is to inject saline as much as possible, because saline will make it. You will be washing it away and dissolving it.
हाइड्रोलाइटिस तो इन एनी केस आपने ज़रूर दे दें, क्योंकि वो और कुछ नहीं तो जो टिश्यू में एडिमा है उसको तो वो रिड्यूस करेगा ही करेगा, और डीकम्प्रेशन भी उसको करेगा टिश्यू को वैसे। तो उससे एक पेशेंट को जो इमीडिएट वास्कुलर कॉम्प्लिकेशन है वो प्रिवेंट कर देगा। यस प्लीज।
Until a year ago, I have been using Ellanse regularly, and then the company stopped importing it. So I've used S, M, and L, all three of them on the face as well. But I never had any complications except for one patient where I encountered that the patient actually traveled a week after getting the filler done. And when she came back after a month, she had nodules. And so I gave her a course of anti-inflammatory initially. I gave her, and then later on I had to give her some oral steroids as well. And eventually the nodules disappeared. But then I was a bit confused because when you check on the internet, there are different reports where some people say that the patient can actually travel right afterwards after having injectables. Would you like to comment that when we're using Ellanse especially, how soon can the patient travel? Because a lot of times they come from different cities and they want the filler done and then they want to travel.
Personally, in my
And why did the nodule occur? Because I was just a bit confused. So I could not actually put my finger on it, whether it was because of traveling or was it because of my technique? Because
I personally think that traveling is a coincidence. I live in Dubai, and it's a travel hub. And I would say, I don't know, 40% of my patients would have some sort of trip in one way or another planned for them to travel straight away. So I don't think that traveling is an issue in that case. Nodules do happen. When someone tells me a nodule, usually nodules happen a while after the injection, not straight away. Now maybe you're unlucky.